All right. So it looks like it's a little after 6:30 now. Probably some stragglers that will continue to come in. But let me first by introducing myself. Hello, I'm Nate Roberts. I'm one of the urologists at the Urology group here. Thank you very much for joining us here for our first webinar talking about BPH. So some things on the Zoom calls, they do have the chat area. If you want to go ahead and throw some questions into the chat, if there's time at the very end, we can go ahead and try to answer some of those. Try to keep them as general questions. I wouldn't say asking specific questions about yourself. If you have further questions about you specifically, we'd be more than happy to see you back in the office to go ahead and discuss that. But let me go ahead and see if I can get my presentation up here for you. So. All right. So here we go. So as mentioned, I'm Nate Roberts. If you're any of my patients who are watching this, you know that I lovingly call myself one of the plumbers. So I am one of the plumbers here at the Urology group. But the talk tonight is benign prostatic hyperplasia, the growing problem. So what is the urinary system? So basically, this is our playground. That includes the kidneys. What is the purpose of the kidneys? It's a filter for the blood. Basically, it takes out the impurities to make the urine. The urine travels down through this tube, which is the ureter. You can see the ureter right here, and it lands inside the bladder. Now, inside the bladder, what is the bladder? The bladder is actually just a very big muscle, and that muscle is able to stretch out to collect the urine. And then when it's socially appropriate, or hopefully when it's socially appropriate, the bladder is able to contract, and then the urine is shot through the urethra. So what are we talking about for the prostate? The prostate sits just below where the bladder sits. You can see this representation right here. But basically, the prostatic urethra travels down through where the prostate sits, and so it kind of envelops all that tissue. So, what are we talking about? I said in the very beginning, it's a growing problem. So, this is a representation of a normal prostate over on that left side of the screen. So basically, when we're younger, the urine goes ahead and shoots through the urethra, which is nice and open. But after the age of 40, it's not uncommon that we start getting urinary symptoms secondary to our prostates getting bigger. So the picture over on the right shows evidence of an enlarged prostate. In this picture, you can actually see some urine that's kind of collecting. The bladder just looks unhappy. But this is something that starts at the age of 40. Now, if you live long enough, honestly, you're probably going to go ahead and have some of these symptoms that occur. This just shows you a graph of as you get older, kind of the representation of where you're seeing the percentage of having evidence of BPH. And by the age of 80, 80% of men will have some sort of incidence of BPH. So this is a very common problem in the United States. 14 million men will be diagnosed with issues of BPH. Now, about half of those patients are taking some sort of therapy. They're taking a prescription for it at 6.7 million. There's actually not a lot of you who are seeing urologists. It's about 1.1 million who are under the care of a urologist. And at the end of the day, out of that 14 million, about 400,000 patients, or less than 2%, will be receiving some sort of intervention for the prostate with us. So when I talk about growing, why does the prostate grow? It's androgen dependent. What is an androgen? It's testosterone, but it's actually not testosterone itself. It's the conversion of testosterone to something called DHT, or dihydrotestosterone, that fuels that prostate growth. Another nice picture of an enlarged prostate down at the bottom here. So term-wise, what is this BPH? What does it stand for? It's benign prostatic hyperplasia. Hyperplasia stands for an increase in cells. So it's an increased number of epithelial and stromal cells found around the urethra. Periurethral means around the urethra inside the prostate. So truth be told, this is actually a diagnosis that can only be done by a pathologist looking at a slide. So when we say BPH, honestly, what do we mean? It really comes down to a constellation of symptoms, and those symptoms are called LUTS, or lower urinary tract symptoms. Lower urinary tract symptoms can kind of fall into two different categories. There's an irritative category, and that's more of symptoms like urgency, frequency, going to the bathroom at night. That's what nocturia stands for. And also sometimes when you feel like you've urinated, you still feel like you're holding on to urination, sensation of incomplete emptying. There's also an obstructive collection of symptoms, and that would be more of a weaker stream. That would be having a harder time getting the stream to start, the stream stopping and starting, feeling like you need to push to get the urine out, and then also getting some dribbling at the very end. So in general, the term lower urinary tract symptoms, it's kind of a complex of symptoms that can be secondary to an enlargement of the prostate. Other things and other terms that we often will use for it will be BPE, which is benign prostatic enlargement, so just the growth of the tissue. Another term is bladder outlet obstruction, so things aren't going through. But honestly, it's not, these lower urinary tract symptoms are not just BPH, but it's just kind of something that we use synonymous with it. But lower urinary tract symptoms can happen for anybody. A woman can come in with having urinary symptoms that we consider as LUTS, but obviously a woman doesn't have a prostate, so that's not where they're coming from. But why we're talking about it is that it's a very common thing after the age of 40 that BPH can lead to some urinary symptoms. So there's two parts that can be going on. And so because of those two parts, there's some medications or procedures that can address both of those issues. But there's a dynamic component of things. There's a smooth muscle that sits around where the prostate sits. So it kind of can compress the urethra by constriction of that smooth muscle. That's the dynamic component of things. There's also a static component. So just the bulk of tissue that's blocking things off can also cause issues by that volume of tissue, making it harder to work. So the way that it starts to create these urinary symptoms is that as the bladder pushes against these two components, the bladder has to work harder and harder for the urine to come through. So just like if I would put a weight in my hand and do a bunch of arm curls, my arm's going to get bigger. The same thing happens to the bladder. But as the bladder wall starts to thicken, as those smooth muscles start to thicken up, it makes it so that the bladder doesn't want to accommodate the urine as easily. So it starts to lose some of its elasticity, and it doesn't store the urine as easily. And then it starts the whole constellation of these symptoms that we just described. So truth be told, when it comes right down to it, when we talk about those urinary symptoms, there's a very large differential diagnosis that is present, and there's sometimes more than one of these factors working at the same time, and that's sometimes as a urologist what we have to try to figure out. So obviously these urinary symptoms can be secondary to having the enlargement of the prostate, but also sometimes they can be secondary to an overactive bladder. So basically, if you trained your bladder over time, that anytime any urine gets on board, it says, get rid of it, get rid of it. Sometimes that can create some issues, and there's separate different ways that we can treat that component of things if that's what your biggest issues are. Urinary tract infections can cause these issues. Stones within the urinary system, that could be anywhere from a stone that's in the kidney or mostly down into the ureter or in the bladder, can create some of these symptoms. When it really comes right down to it, the urination is actually a pretty complex dance of things. It is not just the bladder squeezing and things going out, but there's a lot of signals that are traveling along the spinal cord going up into the brain. But there's times that patients can present with something that we call dysfunctional voiding, which is basically where the bladder and the sphincter, the muscles and how they work, they kind of don't dance in the same time. So the sphincter is supposed to relax, and sometimes if it doesn't do that, it can create those symptoms. There's another term called neurogenic bladder, which kind of deals in a similar way to dysfunctional voiding, but somewhere along those pathways of the spinal cord or the brain, things can kind of mess up that signal as well. So things that can mimic an enlargement of the prostate or outlet obstruction can be strictures, which are scar tissue that's inside the urethra. You can also sometimes have some narrowing of the bladder neck, and that can be secondary to scar tissue or just how you're formed. Inflammation within the bladder or the prostate can sometimes create these symptoms. And then, there are times that people who present with these symptoms can be having something more involved happening. So you can sometimes get these symptoms secondary to different types of cancers, and that could be either bladder or prostate cancer. But for the people who are here on this call, I do want to let you know that more often than not, this is usually a benign process, but sometimes through the workup, we can figure out something else that's going on. But last but not least, sometimes you're on medications. Diuretics are one that oftentimes make more urine, and that can also cause some symptoms. So sometimes stopping those medications or taking them at appropriate times can help with some of the problems that you're having. So when you come into the office, what do we do? So first things first, we got to take a history, and that can kind of help to tease out some of those different differential diagnoses that we can have. So we'll ask you a lot of the different questions about your urinary symptoms. And there's actually a form that we oftentimes will use that kind of ask a lot of those questions, and I'm going to show you that form here shortly. But there's something called the AUA symptom score. There's another term called the IPSS, which is synonymous with that AUA score. But during our evaluation, oftentimes we will do a physical exam, which is the unfortunate part of us doing a digital rectal exam. And that can oftentimes tell us how big, or at least give us a little bit of an idea of how big the prostate is. But sometimes it's only feeling the tip of the iceberg. But the other thing that the physical exam can do is sometimes show us if there's any bad bumps within the prostate, which could be a little bit more concerning for prostate cancer. And if we're feeling bad things, or honestly, if we're going down the road and starting to do treatments, a lot of times we'll ultimately need to do something called a PSA, which is just a blood test. But that's a whole different talk. That's something that's dealing with prostate cancer surveillance. So other things that we check while you're in the office are bladder scans, just to see how well you're emptying your bladder. When your bladder's pushing against all that resistance, sometimes the bladder starts to give up, and sometimes it has a harder time getting everything out, so you can have incomplete bladder emptying. The next line down talks about urinary flow studies. There's a couple of different ways that we can test that, anywhere from something called a uroflow, which is a funnel that we have in the office that can test the speed of the urine. But there's also other ways that we can do that measure pressures, because honestly, there are times that people come in and they complain of a weak stream, and it may be just that the bladder's just not contracting and it's not an outlet issue. And some of these other tests, the urocuff and the urodynamics, can dive a little bit deeper into that. So when we're giving you a workup and we're trying to figure out what's the best avenue of treatment for this, there's oftentimes need for imaging, and that could be anywhere from an ultrasound. And the way that we do ultrasound could be either a pelvic ultrasound. Sometimes we do a transrectal ultrasound, which is a probe that goes into the rectum. If we're concerned about elevated PSAs or concerned about prostate cancer, there are times that we also do prostate MRIs, which will be another way that we can see the size of the prostate, but that can also show us if there's any evidence of any abnormal areas that we would possibly need to sample. But last but not least, everybody's anatomy and how things grow can be different. And so sometimes we need to do a cystoscopy, because the cystoscopy can kind of show us how that tissue is growing. The most common area for the tissue to grow is on the side, so a lot of times it will grow together. But there's also times that we can see tissue growing in the middle, and there's times that this tissue is growing into the bladder. So when we start looking at different treatment options, the cystoscopy can kind of point us in one direction or the other. So this is that symptom score sheet that I was just talking to you about. It's called the AUA symptom score. 7 questions that break down, those lower urinary tract symptoms. The scoring of this can be either mild, moderate, or severe. You can kind of see where those numbers fall. But honestly, the very important question on the bottom talks about your quality of life. So there's times that I have patients who come in and they have a lot of urinary symptoms, but they say, hey, I'm delighted or pleased about it. The way that I really honestly talk to most men about this is I usually say, if you're happy, I'm happy. If you're not happy, I'll go down the rabbit hole to fix it. So if you're comfortable with the way your urinary symptoms are, this is honestly a quality of life issue. So a lot of times we're okay with stepping back and not proceeding with things. But there are times that I have somebody who comes in with a mild symptom score and they're not happy with things. And so oftentimes we will have to be a little bit more aggressive for that patient. So, what are the reasons why we do treatments? And so the indications for us proceeding with some sort of treatment, number one is if you're bothered with the symptoms that you have. So if it's affecting your quality of life, just like what I said, we have plenty of things that we can do to make it better. Now, if you're getting recurrent infections, and when I say infections, I mean in the urinary system, if you start getting issues of recurrent urinary infections inside the urinary system, that oftentimes can warrant us doing some sort of treatment. Hematuria stands for blood in the urine. So if there's a significant amount of blood in the urine that specifically is coming from the prostate, that oftentimes will lead us to, again, proceeding with doing some sort of treatment. So one of the things that we do scan for, and when we talked, is the residuals. And if you're having such a high residual that the bladder is so stretched out that it starts to create pressure, that pressure can push back up into the kidneys, and it actually can damage the kidneys itself. So if you're having such a hard time getting the urine out, that's also something that says, yeah, we need to do something. We need to improve this. So, and if you're unable to get the urine out, if the bladder just can't generate enough pressure, that's obviously something else that we would want to make sure we treated. And then also bladder stones. What are bladder stones meaning? They usually mean that the bladder is not doing a very good job of emptying. So if there's residual urine in place, oftentimes you can get a small stone that over time, if it's not able to move out, can start to get bigger and bigger. And that's usually just because the bladder is not completely emptying itself. So what are our options? Well, one option is we just change some of your behaviors. So doing behavioral modification. There's a laundry list of drug therapies, and that's oftentimes what we start with. But then there's also surgical interventions as well, and we're going to kind of hit on all of these things here. So, the non-surgical management of BPH or the behavioral modification type things, limiting how much fluid you put in. If you don't have as much gas in the tank, your car can't go as far. So limiting how much fluid intake you're doing can definitely help with that. Also, the timing of your fluid. So if you know you're about to take a road trip and every time you drink a lot of fluids, you're going to be in the bathroom and at every rest stop, shutting down fluid intake for that time beforehand can definitely help. If your big issues are urinating at night, oftentimes we'll tell you stop drinking any sort of fluid 2 or 3 hours before you go to bed. Also, the fluids that you take can be important. Water is usually extremely benign to your urinary system. Things like caffeine, they cause a lot of issues because they can produce more urine. So trying to avoid caffeine itself can oftentimes help to reduce a lot of those urinary symptoms, and especially trying to avoid that at night. If you're drinking a lot of caffeinated products at night, that can cause some issues. Also with alcohol, that's another thing that can go ahead and produce more urinary symptoms because it produces more urine output. So if you drink alcohol in the evening, that oftentimes can make you pee more at night. Not that I'm a proponent of drinking, the hard alcohol or wine, but if you are drinking alcoholic beverages, the ones that have more fluid involved with them, for instance, for beer, that oftentimes will do twofold. Number one, the beer has a larger amount of fluid, but then also the components that make you produce more urine just can cause you more urinary symptoms. So sticking to something that has a smaller volume can help. But overall, that's kind of non-surgical aspects of things. As to the drug therapies, there's a whole laundry list of medications that we can do for this. The mainstays of treatment oftentimes are the alpha blockers, but we also have something called 5-alpha reductase inhibitors, PDE5 inhibitors, anticholinergics, and finally beta-3 agonists. So kind of a breakdown of those. Alpha blockers, the way that they worked, if you remember the dynamic and the static components of the prostate, the alpha blockers work on the dynamic component. And so what it does is it helps to relax the smooth muscle. And so there's some of these receptors that are located within the bladder, especially around the bladder neck, but also inside the prostate itself. So with taking these medications, it dilates that smooth muscle and it allows those areas to relax to allow the urine to come through a little bit easier. Now, these originally were blood pressure medications. And so if you're looking at my list of medications that are on the screen, Hitrin and Cardura were blood pressure medications that actually had the added benefit of causing an improvement in the urinary symptoms. So these are non-selective alpha blockers. Over time, they started to find some alpha blockers that worked more just on the urinary system. So you can see the ones that are listed here. There's alfuzosin, tamsulosin, and then silodosin. So, but because of the effects that it can have on the blood pressure, or on the blood vessels itself. It can cause lowering of the blood pressure. One of the ways that it can do that is that when you stand up quickly, sometimes it can cause you to get a little bit of dizziness at that point. We call that orthostatic hypotension, so lowering of the blood pressure when we sit up. But it also can cause dizziness. It can cause a feeling of congestion, and it can cause some sexual side effects as well. More often than not, it doesn't cause issues with the erections, but what it does is that it can cause it so that when you have an orgasm, no material comes out. So you should still have the symptoms or the sensation of an orgasm, but nothing comes out. Some guys freak out about it. Other guys will say it's less cleanup, but that's honestly one of the biggest side effects that we can see with these medications. Now, a next class of medications been around for a good long while. There's two in this class, and these are called alpha reductase inhibitors. So 5 alpha reductase inhibitors. There's 2 in that class. And if you remember from the very start of things of what is feeding the prostate, it's the conversion of testosterone to dihydrotestosterone or DHT. These medications work on blocking that conversion over to DHT. So there's 2 of them. There's finasteride and dutasteride. And honestly, these medications can take anywhere from 6 to 12 months before we truly know if they're going to kick in and help you or not. The most common side effects, not common, but it can cause issues with erectile dysfunction. It can cause issues of formation of breast tissue. That's what's gynecomastia. Sometimes it also can cause some issues with your ejaculation as well. So if we start these medications, it's usually because you have a little bit of a bigger prostate, and that's usually something that we find on the imaging. But honestly, it can take some time before we know if it's truly going to help you or not. Now, the PDE5 inhibitors, the most common that we use in this case, or the only one that's indicated for it, is tadalafil or Cialis. And you're probably wondering why I'm mentioning an erectile dysfunction medication from when it comes to urinary symptoms. So Cialis has 2 versions of it. They have an as-needed pill and they have a daily pill. It lasts in the bloodstream a little bit longer. That's why they have a daily medication. When they were giving it to men on a daily basis to see if it would help them with their urination, a lot of the men were coming running back saying, hey, it not only helped me with my erections, but it also helped me with my urination as well. So if you're having both issues with your erections and also with your prostate causing urinary symptoms, this could be a good 2 birds with 1 stone. What are the most common side effects? It can cause issues of flushing. It can cause issues of headache. Sometimes it can cause issues of reflux. It can cause joint pain and also the nasal congestion. So if we're specifically targeting and having issues of the overactive bladder symptoms, there's 2 segments or 2 areas that we can address. One of them is the anticholinergics. This class of medications have been around since the 70s, and there's a whole laundry list of them that are out there. The most common side effects for them is that it can cause dry eyes, dry mouth, and constipation. There are some concerns that some of these medications can cause some issues with changes in your memory, and there's some concerns about possibly dementia. So when we have older patients, sometimes we like to hesitate on doing these medications. There was a separate class that came out probably about almost 10 years ago called the beta-3 agonist. There's 2 in this class. There's one that's called mirabegron, which is Myrbetriq. The side effects for that one are possibly urinary retention if the medication's working really well. They also can cause some slight increase in the blood pressure with hypertension. It can cause what feels like a head cold and also can cause headache. There's another one called Gymtesa or Virabegron, and that one does not have as much of the blood pressure issues, but it can cause some of the symptoms as you see. But these 2 classes of medications are oftentimes used to try to treat the irritative component of some of these symptoms. So either you've tried the medications, you don't like the side effects, you don't want to take a medication. What are the next steps? Going down further into the rabbit hole of things are surgical intervention. So what is the surgical intervention doing? It's trying to address that static component of these symptoms. So trying to get the blockage out of the urethra, trying to reduce the outlet obstruction that way. How we deal with this, honestly, it runs a gamut. And when we look at sizes of things, size does matter. There are some minimally invasive type procedures that we can do that are indicated for patients whose prostate glands are 30 to 80 grams. What does that mean? The normal size of a prostate is typically 20 to 40 grams, so it's about the size of a walnut. But when we look at the classifications of sizes based off of the AUA, anything that's less than 30 is considered a small prostate. 30 to 80s in BPH, 80 to 150 is a large prostate. 150 or above is considered a very large prostate. So trying to figure out the size of it will kind of address which areas or what may work best for you. But one of the questions that I do get oftentimes is like, Doc, why don't you just cut it out? Well, more often than not, when we cut out the prostate, that's something that we do for prostate cancer, because the side effects from taking out the prostate can be a little bit more than what we can do for some of these interventions here. So if we found prostate cancer and you're having a lot of urinary symptoms, sometimes we do recommend doing what's called a radical prostatectomy or a complete removal of the prostate. But more often than not, we're trying to deal with the tissue that's inside the urethra that's causing the obstruction, and we're trying to take away that part of things. So here's kind of a whole list of the different procedures that are available to us. Some of them are more historic. The top two are not really anything that we do anymore. The one is called a TUMT. That was basically a catheter that was put in that could heat up inside the urethra and destroy the tissue that way. A tuna was where we injected a needle that could heat up the tissue and destroy it that way. The one procedure on here that is actually not done by a urologist is a PAE, or a prostate artery embolization. And that's probably the least invasive way that we can deal with things. And that's where we go into the blood supply. I'm going to show you that in a second, but you can see Resume, TURP, Urolift. There's a different laser procedures we do. There's a high pressure water jet. And finally, there's also a procedure where we can remove it with a simple prostatectomy. But let's take a look at what these are. So the first one here that I just mentioned is the PAE. And this is a depiction of the blood vessels that are traveling down to the prostate. So this is the artery that's traveling into the prostate itself. The interventional radiologist will go through either through the wrist or the groin, and they will inject some gelatin beads into that area, which will cause that prostate tissue to shrink up. So here's a little depiction of what they do. But basically, it's a catheter that's running into the blood supply, and they can get down. You can see it's traveling down from where the bladder sits and then down where the prostate is. And once they're in those terminal vessels that are traveling just to the prostate, they inject that gel material into that area. And that depiction obviously showed you where the prostate shrunk. So, as to the downtime from that procedure, typically it's about a week of downtime. You may have some early on symptoms that can happen, but over here on the side of the left screen, we can see the outcomes of it. That IPSS, once again, is synonymous with the AUA. You can see a great improvement in those scores. There can be an improvement in the maximal flow of the stream, and that can be anywhere from 3 to 10 cc's per second. The prostate volume and how much it's reduced by can be anywhere from 21 to 45%. But as to the symptoms of things, as that tissue is shrinking up, sometimes it can irritate things first. So you may have some burning with urination. You may have some more frequency. You may have some urgency. And that can honestly last for 7 to 10 days. There may be some sloughing of the skin around the penis itself. There's a very rare chance of us ever needing to put a catheter in after that procedure. There is no sexual side effects. And if you're on blood thinners, you can go ahead and keep going with those. So, if you're looking and you're interested in a PAE, once again, there's size criteria, and more often than not, this is something that works better for an enlarged prostate, so something that's greater than 50 grams. If you have a smaller prostate, it may not be the best option for you. But if you're interested, we do work with Rachel Petroviak, who is great. She's honestly done almost 1,000 of these at this point, and she works in the Reston area in a radiology suite. So, other minimally invasive way of doing things, there's something called the Urolift procedure, which is a prostatic urethral lift. And how does that work? It is, if you're looking at the depiction down below here, basically we take an instrument that goes ahead and goes inside the urethra, and then we put an implant into the wall of the tissue. That implant has two small pieces of metal. There's one that goes to the outside of the prostate, and there's one that's inside the urethra called the urethral tab. And what we do is we take that tissue and we push against it, and then we deploy it. And that honestly, at the end, as you can see in step 3, leaves the channel open. Now, typically when we do this procedure, we typically put in 2 to 6 of those implants. That procedure honestly takes us about 15 to 30 minutes to do. We typically do it either in a surgery center, or if you have some comorbidities, sometimes we'll do it in the hospital, but we do it under light sedation, and we're able to put those implants in. So this picture also can show what the urethra looks like when we're done. So that tissue on the left side of the picture is showing where the tissue was obstructing things. And then after we put those implants in, it can open things up. So as to the indication and the sizes of it, this is indicated for patients who have prostates between 30 and 80 grams and has the absence of an obstructing median lobe. You can talk with some of my partners, and I'll show you a slide shortly here about some of us who do them. The company has done them in patients who have median lobes, but oftentimes it's a little bit more challenging. And so the AUA guidelines still don't have it as a component to things. So if you have a median lobe, more often than not, they say you shouldn't do this procedure. So the Urolift and how does it improve things? There's an 11-point reduction in the score. They show that there is an improvement in how strong the stream is. Basically, there's about a 15% retreatment rate at 5 years with these. But the nice thing is side effect wise, or going through the procedure, there is typically not a catheter that's needed. When those implants go into the wall, it can rough things up. So as that implant goes through, it can cause some bleeding. If there's any significant bleeding to the point where we'd be concerned that it could clot off the urethra, then we would leave a catheter in place. That catheter would usually stay in for a day, maybe up to 2 or 3 days before it comes out. But there should be no sexual side effects to these procedures. There should be no issues of the ejaculation issues that you can see. But with those procedures, you can have some short-term pain with it, but that typically resolves after a couple of weeks. In worst-case scenarios, I've seen it last a couple of months. So here are the docs that do it. So as you can see, I do it, Dr. Kennedy, Dr. Lester, Dr. Pruna, and then also Dr. Tran. So the next minimally invasive way of dealing with things is called Resume, or the water vapor thermal therapy. This is indicated also for patients who have a similar size to the Urolift size, which is 30 to 80 grams. But in this case, it's actually indicated for patients who do have that middle knuckle of tissue. I'm going to play this video here for you, and we'll let the video run, and you can listen to it here. Okay, so basically we're scalding it with hot water. So it's a needle that goes into the tissue to go ahead and destroy those cells, and then the body reabsorb that tissue. Similar in that you can see there's an improvement in the flow rate. You can also see a similar improvement in that symptom score with 12 points. Retreatment rate about 15% at 5 years. As to the sexual side effects, also very good. There's no issues of erectile dysfunction. The risk of retrograde ejaculation is very low. It's about 2% that you can see. Now, when we do these procedures, there can be some significant urinary symptoms that happen early on. When we do these, honestly, it can make you feel like you have a horrible urinary tract infection that can last for 2 or 3 weeks. When we inject the steam, it can create an inflammatory reaction that actually can squeeze off the urethra. So we do require a catheter afterwards, and that catheter typically would stay in for 3 to 5 days, depending on how many number of injections of steam that we have to do. But you can see some blood, you can have some burning, you can have urgency, you can have all these urinary symptoms that honestly take 2 or 3 weeks before they settle down. And truth be told, it can take up to 3 months before we really start to see improvements with this procedure. The three of us, Dr. Tran, myself, and Dr. Lester, are the ones who do the resumes. Now, we're now kind of leaving the realm of the quote-unquote minimally invasive ways of doing things, and now we're going to start looking at some of the resection procedures. And there's a whole laundry list of ways that we can resect the tissue. The kind of like the original, the one that's been around almost for 100 years now is the TURP. It's lovingly sometimes called the roto-rooter as well, but it's a transurethral resection of the prostate. So transurethral through the urethra, we take a heated element that goes ahead and shaves down the tissue. But I'm going to go ahead and play a little video of this one so you can also see what that looks like. So in this video, the patient has an enlargement of 3 areas of the prostate itself. It has the tissue that's growing on the side. And in this case, there's what we call a median lobe. And this is actually showing a resection of the median lobe at this point. So you can see as that heated element goes through the tissue, it does cauterize some things. Oftentimes when we're doing this, we have to go back and control some bleeding as well. But basically what we do is, as that picture shows on the left, we resect down the tissue until hopefully we make a nice wide open cavity. So when it comes right down to it, this is what's been around the longest. And honestly, when a new procedure comes out, that's typically what it's compared to. So as to improvement of things, you can see there's a great improvement in the flow of things. The symptom score improvement is great. It's about a 16-point improvement in that. Side effects from this, it can cause erectile dysfunction. When we started doing these, there's different types of energy that we use. There's something called monopolar energy, and then there's something called bipolar energy. The original resections were monopolar energy. They had more sexual side effects that can happen with them more often than not. Most of us who do these procedures these days are using bipolar energy, which doesn't travel as through the tissue as far. So it typically doesn't cause as many of the issues of erections. One of the things that it can cause is retrograde ejaculation. Once again, that's when you have an orgasm. The material, instead of going downstream, goes backwards. And that can happen up to 70% of the times when we do these. As to retreatments, the breakdown of it is typically 1 to 2% of patients need retreatment per year. Some of the other things that you can experience are scar tissue in the urethra. That's about a 4% chance of seeing that. And then issues of incontinence or leakage of urine, that's about a 2% risk. The ones, when we go through training, this is kind of how we oftentimes learn how to do the removal or the prostate procedures. And so pretty much everybody in the group does these. So just pretty much talk to one of us at the urology group because we probably do it. Next is showing a video of one of the 2 laser procedures that we can do. This one is called the HOLEP, or the holmium laser enucleation of the prostate. Fun, fancy words of using a laser to go ahead and carve out that tissue instead of using the heated element. The laser can do 2 things. It can cut, but then it also can cauterize some of the small vessels. This has been around since the 90s. In order to do these procedures, we do need a special secondary device called a morcellator to go ahead and chew up the tissue that's present. But here's a little video of me talking about it. And that's the morcellator. So HOLEPs, the risk of reoperation is some of the best that you'll see for these. There's one trial that shows that there's a 1.1% chance at 8 years of needing to do some sort of repeat procedure. The improvements in the flow are pretty good, as you can see. Improvement in the symptom scores are also really good. And when you start getting larger glands, that's honestly where we start to see the benefits of these procedures. So if you're talking or doing these procedures on greater than 80-gram prostates, it shows that we have some pretty good outcomes with this. Now, compared to TURPs, there's a very low risk of needing any sort of blood transfusion. Typically for catheters, the catheters are in for short periods of time. Similar to a TURP, your risk of having either scar tissue in the urethra or getting a scar tissue around the bladder neck are about 3 to 4%. The risk of issues of the ejaculation are similar to about 70%. The risk of incontinence at year 1 is about 1.1%. And in general, these procedures take a little bit longer than a traditional TURP, but especially for the larger glands, this may be beneficial. So out of the group, I'm the one who does these procedures. So if you're interested, you can always see me as well. Next is something called the GreenLight laser. The GreenLight is a KTP laser. It's a different laser energy. And this one actually works with the absorption of hemoglobin. So it kind of is on that wavelength for the laser. And honestly, what that means is that it's usually pretty hemostatic when we use this agent. But when we do the GreenLight, it's actually a vaporization of the tissue. So we basically melt the tissue. This procedure is oftentimes an outpatient. The HOLEP, the home laser, is 80% of the time it's an outpatient. And the risk of bleeding after these, like I said, is not as significant as doing the TURP. But here is this video just showing an ablation of that tissue. You can see over on the right side of the patient's prostate actually it's the patient's left, but on our screen, the right side, that white tissue, that's an area that's already been ablated. But you can kind of see that tissue that's kind of just melting in front of that area. So we basically melt down the prostate tissue in order to open up the channel. So also a great procedure. And when we look at the procedures that we do, more often than not, looking at the resection procedures versus the procedures that don't take out tissue, usually you're going to see a greater improvement in your symptom scores. You're usually going to see an improvement, a greater flow rate. With this one, and depending on how good you are at it, there can be a little bit of a higher retreatment rate. You can see at 52 months, it was 7% in one trial. As I showed in another slide, it has a very low transfusion risk. It can cause some scar tissue, similar to all the other ones. It's about a 4% chance of causing that. The way that this laser energy is absorbed into the tissue, it can create some irritation. And so you can have some more frequency, urgency, and burning with urination that can last for the first 4 to 6 weeks. This one also can have some issues with the ejaculation as well. Although it's a little bit lower, it's about a 30% chance. Dr. Lilas, one of my partners, is one who still can do this procedure. Now, the most recent procedure in the resection realm that just came around is something called an Aquablation, or a robotic water jet therapy. And what this is a water jet. So it's basically using a pressure washer on your prostate. But the way that it works and if you've ever seen videos with doing like high pressure water, this honestly can even cut through metal. But it's a programmable robot that has the ability for us to adjust the pressure of things. And what we do is we create a program, and through that program, we're able to resect the tissue real time with ultrasound guidance. So this actually shows evidence, or this shows an ultrasound that is being performed. So it's 2 probes. It's one probe that goes into the rectum and as with all these procedures, they're all done under anesthesia. So you would be asleep for it. But it is a probe that goes into the rectum, and through that probe, it's an ultrasound, and it can depict the prostate here. So what we're looking at in this case, this patient's ultrasound is showing evidence of a big knuckle of tissue inside the bladder. And so sometimes we can even create a program specifically for this. but this also shows evidence of where that other tissue is present. But we're able to do a program that shows us where the bladder neck is, it shows us where the prostate tissue is, and it also will show us where everything ends, down at the very back where the sphincter sits. And then through that, we go ahead and we'll hit a button, and I'm just going to go ahead and show you this video, which kind of just shows you the depiction of it. So there's an actual procedure that's happening on the bottom of the screen here, and that's showing the pressure resecting the tissue. And then as we go along, this also is showing visually of what things look like as that tissue is being resected. But this area right here is depicting the bladder neck. This is kind of down here where the rectum sits. But as that prostate tissue is being ablated, the fluid is flowing out. So all that tissue that's being resected is being taken out. Now, typically, there's no pathology if you purely just use the water jet to do the procedure itself. But sometimes there can be a little tissue left over at the end. So more often than not, what we'll do is afterwards we'll go in and we'll kind of take away some of the soft tissue. If there's any knuckles of tissue that are still present, we sometimes will send that off to get it analyzed. But as to procedures, this one has been around for about 5 years. The symptom score improvement you can see is great. So it's 16-point improvement. The flow rate is great. Quality of life improvement also looks good. As to the sexual side effects for this procedure, they're a lot less. So with the erectile dysfunction, in their literature, it does not report any issues of erectile dysfunction. But the risk of having issues with the ejaculation, to have that problems of retrograde ejaculation, it's pretty low. It's 10 to 11% for that procedure. The risk of incontinence, honestly, is about 0.5 to 1%. There is a little bit of a higher risk of transfusion when it looks at, and when we look at the literature for it, the risk of needing to give blood for these procedures is up to 4%. And once again, it's a water jet, so if it's cutting through a blood vessel, there are times that those vessels can bleed. And that's one of the reasons why at the end we go in and we cauterize some things. But overall, there is a little bit of a higher risk of bleeding with these procedures. Now, the risk of staying over or the possibilities of staying in the hospital overnight with these procedures, probably about a 50-50 shot. You do have a catheter in afterwards, similar to the other resection procedures that we do. These catheters usually stay in for a couple of days, so like 2 days to 4 days, just depending on what we end up seeing or how big your prostate is to start. So there's 4 of us who are doing these procedures: Dr. Lilas, myself, Dr. Lester, and also Dr. Young. Now, for the really big glands, similar to the HOLEP, there is another procedure that can be done where we remove the tissue. When somebody would come in originally and have a really large prostate, we would sometimes do a simple prostatectomy, and we would do it as an open procedure, which means that we would make an incision below the bladder about this big. We would go in and we would actually cut open the bladder, and then we would carve out that tissue. Honestly, sometimes we would use our finger to go ahead and core out that growth of tissue, and then we would remove that knuckle of tissue. With the advent of the Differential robot, we can do this robotically. And this picture shows what's called a transvesical approach, so through the bladder. But basically, we're able to go through the. Sorry, my dog just came in, so she's saying hello to me. But we're able to go through the. We're able to go through the bladder to get down to the prostate tissue, and we're able to go ahead and use the instruments to go ahead and carve out that growth of tissue. So that is an option that's available to you. But typically that's for the larger glands. So I would typically say that's for the very large glands, 150 plus gram size. So the improvements that you can see are obviously pretty great. You can see an improvement in your symptom scores, anywhere from 8 to a 22-point improvement. The flow rate gets better. The residuals honestly look great afterwards. Similar to the Aquablation, you can need transfusions. The honest stay of these, more often than not, I would tell you it's probably a one-night stay, so you're usually going home the next day. The catheters typically will stay in a little bit longer. The risk of a bladder neck contracture is less with these, so it's about a less than a 1% chance. If you're interested in having these procedures done for your extremely large prostate, these are the providers that you can go to. Dr. Schenk, Dr. Young, Dr. Lilas, and Dr. Tran. So overall, I will tell you this, our website, which is the Urology Group, Virginia.com, has a lot of information on it. We have a section that goes through all of these issues, all these BPH stuff, and has discussions on all these different procedures. If you're interested, go there. You can take a look at it. But the other part of it is that if you want to talk about it more, definitely make it a consultation in the office with any of my providers, and even with my APPs, the advanced practitioners. Can't even speak anymore. Been talking too long, but you can go ahead and talk about all these things, and we can try to direct you in the right avenue to make things better for you. So it's a common problem, and we can do treatments to make you pee like this guy here. All right. So let me stop this and let me see if I can see if there's been any questions that have been asked. There's one question about why is there nothing like a stent inside the urethra. So there used to be a metal stent that we would place inside the urethra to open up the channel. That they were wrought with issues that they would start to migrate, and so there was something like that previously, and honestly, they had a lot of issues with them. So the next question, who's treating the 3 million under treatment but not by urologists? It's your primary care, so either your family medicine doctor, your internal medicine doctor. You know, sometimes people, see their cardiologist, and I know cardiologists sometimes give you those blood pressure medications, so sometimes they're treating it as well. And so if you're going the medication route, they can definitely help out in those areas. But, I would tell you, we can either try to get you off of those medications to get you away from there with those procedures. But, that's who's treating those folks. The next question is, do you recommend taking blood pressure meds in the morning if nocturia is the main component? It depends on the blood pressure medication that you're talking about. The ones that increase production of urine, so the diuretics, those are the ones that I would say are best to take in the morning if that's possible. So your hydrochlorothiazide, your loop diuretics like furosemide, there's a couple of different ones out there. And those are the ones that I would say that you should try to do in the morning if you can. If not, if you have to take them later in the day, usually taking them earlier in the afternoon is better, just so that they can start to ramp down by the time you're trying to go to bed. Let's see, where is or are the sphincters? So in your urinary system, you have two sphincters. You have one sphincter that sits inside where the prostate sits. That's called the internal sphincter. And that's kind of a continuation of the bladder muscle that spirals around inside that area. And then there's another muscle that's under your control called the external sphincter that sits just below the prostate. So that's the one that you figured out how to use when you became potty trained as a kid. Okay, let's see. Differences between Avodart and tamsulosin. If the results with tamsulosin are not as good, does it help to switch or take both? And then there's a question about non-prescription medications, so some of the supplements like saw palmetto, and where are they? So honestly, there are times that we have patients who take both medications. I have patients who end up being on 3 separate medications. And so sometimes people are really hesitant to proceed with doing surgical procedures, and they want to try all the different therapies. So when you talk about the tamsulosin and Avodart, there is even a product that's a combination of those 2 medications. So that addresses both of those components, both the dynamic component with the smooth muscle, and that's what the tamsulosin is affecting, but then it affects the static component with the shrinking of the tissue. So yes, absolutely, taking both of those medications at the same time can give benefit. There's literature that shows there's a reduced or a less likelihood of having urinary retention if you take the combination of those meds versus just taking one by themselves. So, as to the pros and cons of the different procedures, I kind of listed it here with with the slides, kind of giving you a broad spectrum of things. Again, if you're interested in those, let's have you come in and we can talk about it a little bit more. Next question about how effective are bladder training exercises. So Kegel exercises, they're an exercise of the pelvic floor. And how does that work? They are a contraction of the muscles that are sitting in the pelvic floor. The way that I usually tell folks how to do those exercises is that when you're urinating, stop your stream. If you're able to stop your stream, then you're using the right muscles. It's not really an ab contraction. It's not really a glute contraction. It's kind of a contraction underneath. There's two ways that you can do those exercises. They can be a static contraction. The static contraction oftentimes can work really well or if you're having issues of leakage of urine. If you do have an overactive bladder, there are times that you can retrain your bladder with doing some of these exercises. The way that I tell people to do that is that you can do quick flicks or you can do quick action Kegel contractions. So if you get the urge to go to the bathroom and you just went 5 minutes ago and you really shouldn't go and it's your bladder being a little overactive, you can do 5 of those contractions very quickly, and then that can give you some more time. And over time, you can retrain your bladder to hold on to the urine a little bit more. There's a question about can BPH cause PSA levels to be elevated? Absolutely. So there is a component that what is PSA? Like I said, that's for another talk, but PSA stands for prostate-specific antigen. It can be elevated for prostate cancer, but it can be elevated just because you have a higher volume of tissue. And so having a larger prostate or more cells of prostate, more PSA can be produced. So absolutely, having an elevated PSA doesn't automatically equate to having cancer, but it can be something that we see in somebody who has an elevated has an enlarged prostate. So, as to the questions about a bladder, so there's a question that says, can minimally invasive prostate surgery be done on someone with an atonic bladder? You can do surgeries on somebody who has an atonic bladder. What I will typically tell you, in order for you to be successful at urinating, you need 2 things. You need a bladder that's able to contract, and you need a tract that's open. As a urologist, I can affect the tract. I can open up the tract. At this point, there is really nothing that we can do that makes the bladder work better. If your bladder just doesn't want to contract very well, there's times that doing a minimally invasive procedure honestly may not work as well. I will tell you, if you have a bladder that's not working as well, sometimes doing a resection procedure is what we would recommend because that's maximally getting reduced outlet obstruction. So sometimes you can see a little bit of benefits with that. I'm going to go ahead and just take one more question here. And then it is 7:30. So I will say that we can sign off for the night. But once again, if you do have further questions, my suggestion would be for you to go ahead and schedule an appointment to come on in so we can talk about it. And we'll talk about with the more invasive procedures, can they damage the urethra and result in longer recovery time? So in general, when we do resection procedures, it is cutting through the urethra in order to get to the tissue. With doing that, the recovery time is typically more. So the downtime for things like the Resume or the Urolift is honestly 2, maybe 3 weeks. The downtime from doing the resection procedures more often than not is 3 to 4 weeks. But yeah, so you can have some more issues that happen with that. But overall, that's pretty much what I would say. As to this presentation, it has been recorded. So if you are interested in getting the presentation itself, we can go ahead and send it to you. If you have anybody who you know who was trying to get on, they weren't able to do it, you can always let them know that we can email it. This is not the last time we're going to do this talk. Probably in the next 2 to 3 months, one of my other partners will go ahead and they will be doing this presentation as well. But I want to thank you all for your time. And as I said, make an appointment. We can go ahead and discuss it. But again, thank you so much, and have a great night.